it's now open to questions from the audience to our panel. If anyone has a question, please raise your hand and a mic will be brought down to you, and please state who you are and where you're from.
Hi. We've talked a lot about collaborative working this afternoon and everybody working together, but nobody's mentioned the ambulance service. We transport your patients around from hospital to hospital, and it's very rare that anybody actually gives us any infection control information about the patients, so quite often we're working blind. Is this something that can be highlighted and we can sort out and share information a little bit better?
Yes, you should be told. I think there's been lots of clear guidance about communication, and it does include the ambulance service, so it's not happening. I would put your hand up and say, why is it not happening? Simple as that.
If you want to improve the system, the one thing I've learned in my industry is we have a huge poster with the Titanic and an iceberg. Why? Because the information passed from the bridge to the captain broke down. But the iceberg is an acronym for ICE. And what we say is information, communication, education. You've got to use all three. If you don't, only one needs to break down and it all fails like a deck of cards. You get the information, you educate people with it, and you communicate it to those who haven't been. So it's important that information is shared. I've seen ambulance crews be very good, I've seen them being very bad. I've seen hospitals not pass information on to primary care, to care homes. I've seen GP practices. In fact, I've heard from my experience in the last few days with my family, the social services don't even communicate with GP practices, with the elderly. We have to get better. We have huge amounts of technology. We have the most modern communication system in the world, but we have very little interface with human beings. Any other questions?
Good afternoon. Unlike most of the medical professionals here, I'm not a full-time medic, but I have had experience on the other side of suffering an extremely life-threatening hospital-acquired infection following open heart surgery and a quintuple bypass. A frightening experience which took me back into intensive care following remedial surgery. I was wondering how common are extreme life-threatening infections following open heart surgery. I wasn't even told which infection I had. And this was an experience nearly 5 years ago and has, with regard to invasive cardiac surgery, have infections become more common in the last 5 years, less common? Should people be worried with the growth of some of the infections we've been discussed today? I'm just wondering a little bit whether the panel has any information.
Our annual report for surgical site infection should give some information on levels of infection following cardiac surgery. But I can't tell you about how many of them are serious and life-threatening.
Is there anyone else who wants to ask a question?
Hi, my question really is for regards to educational material for patients. Because at the minute, I'm from Central Manchester CCG, we've been using Treat Your Infection leaflets. And what we found with our locality is the amount of people who don't speak English and having the material available in other languages. Is there any kind of progress into making that? For one of them is particularly Arabic. Now we have apparently our population would ideally need these, but they're not currently available on the RCGP website, even though other ones are. So I was just wondering whether or not that would be available as well as other materials that you're obviously promoting to the public.
I think it is available in different languages.
Sorry, not in Arabic.
Not in Arabic. Okay. Maybe we'll make some requests to have it translated in Arabic for you.
Have you looked at the I can't remember exactly. It's the gov.uk. There's an antibiotic awareness section. We have a number of resources there, and they're in a number of languages. I can't think of the top of my head if we have Arabic, but have you looked on
Well, I was just thinking
the
in general,
website as well?
for that particular one, it's been really useful. I think at the beginning, earlier on today, there was a discussion about obviously when patients present and obviously having some sort of like finishing material to stop without actually having to write a prescription, particularly for GPs. And we found that's been really, really helpful. But as we're saying, we've been told that some of the languages that are, I think the Somalian we've had printed is quite an old-fashioned language that's currently being used rather than the modern Somalian language. And I don't know whether or not anyone's looked at just basically updating this information, and just generally on your websites, if you're promoting further materials, whether or not we are looking at other ways. You know, we're expecting people to be able to read English. Do we have them in audio? You know, other languages, Braille, all those kind of things. Are those being looked at in any way?
Not as far as I'm aware. I think you make a very valid point. I think quite often people who've come over to this country who don't necessarily speak English as their first language, we know there's a high illiteracy rate anyway. So actually the suggestion you make of some oral type of recorded sort of message might be quite sort of useful, I think, in sort of some ways. I'll take that away as an action from this sort of conference and speak to Cleona McNulty, who heads up the primary care unit, just to explore with her what their plans are. But I think that's an excellent idea.
Is there anyone else who wants to ask a question?
Rachel Leff from Luton and Dunstable Hospital. I was very much interested about the surgical site infection surveillance and the whole thing about the AMS programme for making sure that an antibiotic is given within 1 hour. Has there been any work looking at a way how antibiotics, if it's given within 15 minutes, whether that has got an advantage over 30 minutes, 45 minutes, an hour? I was just wondering whether there's any work being done on that.
I don't have that information at the moment. I'll have to look into it and get back to you.
So there has been various studies that have looked at this, and there's been this big debate, is it within 30 minutes or sort of 60 minutes? And there has been some more recent stuff that's saying actually that golden window perhaps isn't as important as you think it is. However, depending on the type of surgery that you're undertaking, if you certainly know that it's something that has a high surgical site infection rate, so large bowel surgery as an example, I think it comes back to what I said before about the safer surgical sort of checklist. It's actually that question is, one, have you given the antibiotics? If you know it's going to be an operation that may last a long period of time, planning when you're next due to redose, whether you have large sort of blood loss or it's that sort of long sort of operation. And actually having that proper discussion sort of there and then. Anecdotally, I do hear reports back from anaesthetists and others that there may be a degree of lip service just paid to this type of thing. But actually it's there for a really sort of good reason. Everybody should be doing their audits on at least an annual basis around some of these elements. And I would say you just have to sort of tie in very carefully your sort of questioning, actually, when was the antibiotic given? And actually asking sort of the outcomes sort of with it. My personal view is most surgeons know their infection rates privately. They all carry little books with them, and even though we have maybe a quarter at a time of SSRI things, most of you ever have gone to morbidity and mortality meetings that have taken place within the various specialties, they will discuss infections that come up and things like that. So I do believe it's sort of out there. How much of a difference it makes with things we've got very low infection rates, I'm not sure how much of a difference it makes. But we've got to remember, antibiotics are only one small element within the whole surgical site infection sort of process. There's lots of other things that are important, the environment that's sort of taking place on there, length of surgery, expertise, all the things that have been referred to in the NICE guidance that was published a few years ago.
The lady at the top.
More of an observation towards Richard, actually. Looking at the transitioning patients from primary to secondary care and backwards. As somebody who works in primary care as an independent prescriber, it's quite scary really that we don't have the information to hand, that the patient's discharge notes, the GPs have them, but as an AHP I don't necessarily have access to them at that point of care. Personally, the only way around it I can see is patient-held records as some way of managing that information, because we just don't have that. It just saves us time to prescribe the antibiotics at the time without having to refer back to the GP with that information. I just wonder what you thought about that.
I think referring to the earlier question for the ambulance service, I think it's the same issue. Is once the patient leaves a kind of an acute care setting where all the care is delivered as kind of one considered bundle, the information just becomes very fragmented, and quite often the patient is the only person who may have all that information, and unfortunately the time that we intervene with them is the time when they're least able to access that information. And we need to remember that for patients as well, it's always context specific. You know, if someone said to me 3 years ago, you've got C. diff, and now I'm having a heart attack, I'm not sure it's the first thing I'd be telling the ambulance man when they came to recover me to a hospital. So I think until we get to some kind of utopian world where there is some kind of patient-held or single system process, I think that these are the challenges. Going back to your ICE model, you know, trying to improve communication, and if there isn't now, you need to look potentially a clear route where this can be addressed through the clinical commissioning group with the secondary care providers, because it's clearly a gap. And quite often the people who are sat around the table aren't aware there's a gap until it's escalated to them. But that's something that I'll definitely be taking back to our organisation, saying, you know, how do we get that information to guys like you for Bolton Integrated Care?
Right, thank you.
So again, sorry, no solution.
One of the questions I would ask is, the summary care record was put in place as a way of trying to share information much more sort of broadly around. I know our experience in Leeds now, it's much more available that people can actually see that top level sort of summary. As far as I'm aware, there was meant to be rolling out, certainly across sort of England. It may be worth going and ask the question of how is it rolling out amongst your local health economy.
Just as an add-on to that, what a lot of people have approached me about is the fact that we seem to be very good at selling our medical information to insurance companies, to research people and things like that, but we can't even pass it on from one hospital to another. We really are poor at it. As I said before, we have all this communication. I have a wealth of information about anything I want at my fingertips through the internet. We can't even get an intranet in the NHS, because if I go down south and have an accident, they've got no record of me. They are having to rely on people I'm with. Even my father, who was taken to his local hospital, they had to ask the family what medication he was on. He only lives 10 miles away. Surely we could have had a communication system to his GP practice to access his medical records. But they had to ask the family about allergies and things like that. Communication is key, trust me. If we don't get it right, everything will fail. Infection control, everything.